Hello, I'm Beck Elvey. Welcome to my presentation on extended access to general practice, engaging practices and patients. I'll start off with a quick definition and some context. So extended access to primary care is the provision of routine general practice outside core hours. It's part of improving access to primary care more generally, which has been high on the health policy agenda in England, certainly since 2013, and there are numerous documents available on these policies. I've just listed just a couple here, both nationally and locally here in Manchester. Since 2018, all CCGs in England have been required to commission extended access to primary care. Since 2014, extended access services have rolled out across Greater Manchester, and Clark GM was commissioned to undertake service evaluations. So we completed 3 evaluation studies which covered schemes running in 9 CCG areas across Manchester. So in terms of the nature of these services, they are providing pre-booked appointments, so it's not an urgent care service, it's not out of hours. Patients can't come on any sort of drop-in or walk-in basis. So patients tend to access the appointments by contacting their usual GP practice, looking for an appointment, and reception staff will offer an extended access appointment as one of the options and book into that if that's appropriate for the patient. They all run from on a hub system, so each CCG area had between 1 and 5 premises where the appointments ran from. They ran during weekend mornings and during the evenings during the week, and all sites provided appointments with GPs and some with nurses and healthcare assistants. So there was some variation in the detail of what was provided, but this is a general overview. As I said, we carried out 3 service evaluations. These were all mixed method studies with both quantitative components, which focused on activity and utilisation levels and impact on other services, and qualitative work, which focused on understanding the processes around implementation. I was involved with the qualitative work, and this is what I'm going to talk about here. So for this, our sampling strategy was purposive, meaning we sought to interview the relevant people at each site. We used semi-structured interviews, which we audio recorded, and these were transcribed, and we carried out thematic analysis. So through our analysis process, we identified a number of core themes which were cross-cutting and tended to run across the data in all 3 studies. And here I'm focusing on just one of these themes, which is communication and engagement between stakeholders at extended access schemes. We carried out 97 interviews in total across the 9 CCG areas. As I said, we interviewed people in a range of roles, so this included CCG commissioners, people in managerial or strategic roles in provider organisations, which tended to be GP federations, and in the individual practices we interviewed GPs, nurses, practice managers and receptionists. So this key theme of communication and engagement has 3 sub-themes: conceptualising extended access, engagement with local practices, and engagement with patients. And I'm going to talk through each of these in turn. So conceptualising extended access. I said there was some variation in exactly what was provided at each site, and actually during the interviews we noticed that the actual nature and purpose of the schemes seemed to be expressed in different ways. So during our analysis we looked at this in more detail and we found some conflicting views. So some people thought that extended access really was an extension of routine primary care, as illustrated in the first quote here from a commissioner. saying we have to be mindful that we've invested in a service that's trying to enhance routine primary care. It's not urgent care. However, the second quote here from the GP suggests something different. As he says, if someone calls up for an appointment, they need to be seen, we will offer them an appointment. So it's very much seen as an overflow and an adjunct to the core services. So it doesn't seem to be seen as routine care provided during different hours, but actually a different kind of service for a much narrower group of issues. Several sites actually made changes to what they were providing over time, and this ongoing debate about what services were or could or should be is further illustrated in the quote here from a commissioner saying, it's the identity crisis of it, isn't it? That's the thing I struggle with the most. We've already moved in our discussions at steering groups. We were adamant initially that these are routine, pre-bookable appointments and that's that. And then you've got your 4-hour pressures locally, etc. and in A&E. So already we're moving into that dialogue of we need to maybe open up some of these for urgent appointments as a result of some of those patients. So again, it's the identity of it. It's what are we trying to do here is the thing. In terms of engagement with local general practices, all sites involve pretty complex networks of organisations. So CCGs as commissioners had to work with local practices to set up the services, and in between there were often GP federations functioning as provider organisations. There were plenty of positive examples of these various parties working together. It seemed that existing working relationships could be an enabler of engagement, so it was sometimes easier to set things up when people already knew each other. But work to establish the schemes could also foster new relationships, and there were examples of people working together when they hadn't before. So the site lead quoted here said, one of the good things to come of the scheme is that the area as a locality has drawn together at the general practice level. And this was a view that was also echoed by practice managers in particular, who had had more contact with their counterparts in local practices and found they were contacting each other and working through problems together more than they had done before. However, there was some variation in buy-in to the schemes. Some GPs were sceptical about extended access in principle and didn't think it was the right way to manage demand for appointments, or were even concerned that it could increase demand and therefore workload. Others felt that their waiting times for appointments were manageable anyway, and there wasn't actually a need for these additional appointments. There was some criticism of site leads, both individuals and organisations, usually GP federations, in terms of the way they went about communicating with local practices. This was mainly around ineffective or insufficient communication, and not having enough face-to-face contact, so relying too much on emails or letters was singled out several times. And this is illustrated by the quote here from a GP neighbourhood lead saying there hasn't been that sense of engagement with the clinicians to really try and get them to become engaged with it. I think they felt that's on the too hard to do list. Finally, in terms of engaging with patients, there were a range of approaches to this, ranging from one site that had an extensive promotion campaign with adverts on the side of local buses, through to some sites not promoting the service directly to patients at all, and in between that, most sites using things like leaflets and posters in practice waiting rooms. In terms of how patients were referred into and actually accessed the service, a few sites had self-referral through direct booking lines, but most, as I described at the start, relied on patients contacting their practice and being booked in. However, this wasn't always a reliable access route for patients, as illustrated by this quote here from a receptionist. So he's talking first about a different receptionist here. She's very switched on to the extended access service, but it's other receptionists I think struggle. They forget about the extended access service sometimes, I think, because it's a separate system you've got to log into, and it can be a bit complicated sometimes because you're asking patients to attend a hub location for their appointments. Sometimes they don't offer extended access appointments. So perhaps particularly where the service wasn't widely publicised, this demand was moderated by practice staff awareness, by their understanding of or their attitude towards the service, and hence the likelihood that they would refer patients on. So our findings have set out the range of views on extended access in terms of how they're conceptualised and practice and patient engagement. But what might be some of the implications of all of this? When there was a clear vision of the service and good buy-in from local practices, staff could enjoy working together, providing a service they thought was worthwhile, and patients could benefit from greater choice about accessing primary care. However, where there was less agreement with either the principle of the service, or the trusting relationships were lacking, or there wasn't a clear message about the nature and purpose of the service, perhaps that identity crisis that the commissioner we quoted referred to. Implications included local GPs or nurses not engaging to the extent of not putting themselves forward to run sessions, so some sessions simply didn't run at all, or where sessions did run but reception staff weren't engaged, patients didn't get the option to use those appointments. And in fact, our quantitative findings do show variation both in provision of sessions and utilisation of appointments. This has implications for equity of access and also raises questions about extended access policies and the reality of implementing them. So my presentation ends here. Thank you for listening. I've put links here to our main papers and reports that cover our quantitative and qualitative work, or please feel free to get in touch. Thank you.